Good afternoon. Thank you very much to the organizers for inviting me to speak to you about some of the evidence that we have found on how progesterone may be used to some extent to possibly prevent preeclampsia. I don't have any conflicts of interest to declare, but I should say that I'm employed by the University of Oxford. My salary is paid by the National Institute for Health Research, and I work clinically for Oxford University Hospitals and the Fertility Partnership in the UK. And I should also say that some of the research that I will present during this talk was initiated and published by myself. Now, why progesterone? Well, we all know from medical school that progesterone is absolutely paramount for the maintenance of pregnancy. And what's really interesting to me is to think back to the days when I was in medical school and to have people say to me as a dogma that one of the fundamental pillars of reproductive medicine was the fact that the luteal phase always lasted 14 days because that was the lifespan of the corpus luteum. And then I started practicing gynecology and started encountering women who would come to the clinic and say, "Oh, actually, I think my luteal phase is really short." And at first, I was entirely puzzled by that statement. And then throughout the years, I started realizing that, in fact, it is a thing. An inadequate luteal phase is absolutely a thing, um, be it because the corpus luteum doesn't secrete enough progesterone or because it doesn't secrete enough progesterone for long enough to sustain a pregnancy in its early stages. Um, so one of the experiments that illustrate this importance of the corpus luteum so well is one that was done in the 1970s. Essentially, women presented requesting abortions for social reasons, pregnancy terminations. And at the time in America, people turned around and said, "Yeah, that's fine. We will give you your termination. But do you mind if, as part of a study, we remove the corpus luteum from your ovary?" And surprisingly, some people said yes to that. And what was absolutely fascinating from the results of that study was the fact that if people had their corpora lutea removed before around 7 to 8 weeks of gestation, no one made it to their termination date. However, if the corpus luteum was surgically removed after around 8 weeks of gestation, then the placenta by that time would have taken over the synthesis of estradiol and progesterone, and pregnancies tended to continue, and women then came in a few days later for their abortions. And this experiment taught us two important things. On the one hand, the fact that in the absence of a corpus luteum, pregnancy just can't exist unless we give women uh, additional estradiol and progesterone in an exogenous form. And that is something that we do in frozen embryo cycles most of the time, really. And the second thing it taught us was the fact that after around 8 weeks of gestation, the placenta will take over the steroid synthesis of endogenous hormones and then continue it until the end of pregnancy. What we know is that no one truly has demonstrated categorically in the literature the point at which that transition truly occurs. In other words, the best evidence that I've found on this dates back to 2008, where colleagues in Australia studied pregnant women and realized that more than 4 out of 5 women, 82% of people, still had a visible corpus luteum in their ovaries at around 10 to 13 weeks of gestation, suggesting that that 8 week threshold truly isn't absolutely set in stone. And this is another example of why that isn't the case. This was us a few weeks ago operating on someone here in Oxford with a very, very large parafibril cyst. And what you can see there is that at 10 weeks of gestation, the corpus luteum is well pronounced and very vascular, probably working away just as hard as that placenta would have done at that point. Another example of how important the corpus luteum is stems from the world of IVF, actually. And for those of you who are less familiar with IVF, and forgive me if I am over-explaining, but IVF was designed initially to treat people in whom tubes were blocked, so women with blocked tubes, because the whole point was to monitor that person's natural menstrual cycle, try and identify when they might ovulate, and then go in with a laparoscope and collect the fluid from the one follicle that would have developed, and then mix the egg that hopefully would have been in that fluid with sperm outside the body, and then create embryos that one would transfer back into that woman's uterus. And that is why Edward, Steptoe, and Purdy developed IVF to begin with. But what they realized was that in order to maximize the effectiveness of the intervention, they were able to use ovarian stimulation, and that was usually with human menopause gonadotropin. But then they came to a paradigm shift actually, because they realized that once they started stimulating people's ovaries, they stopped having pregnancies altogether, particularly in people who did not receive any sort of luteal phase support. In fact, it was only women to whom some form of luteal support had been administered, usually with the HCG plus or minus progesterone, that achieved a pregnancy. And this was so paramount for them at the time that before they realized this, before they realized that luteal support was absolutely crucial in fresh IVF cycles, which were the only IVF cycles that they did at the time, before they realized that, they actually considered abandoning ovarian stimulation altogether and going back to monitoring people's natural cycles. And we know that the underlying theme here, the common thread, is progesterone, a hormone that was discovered in the 1930s. It has been the subject of Nobel-winning research. And over the past century or so, we've come to appreciate that progesterone has a myriad of effects across the body, not just uterine, but also extrapelvic, in terms of facilitating immune regulation, inducing the endometrial secretory function, but also achieving a state of permissiveness within the endometrium, in addition to ensuring that the myometrium itself is quiescent through calcium-mediated mechanisms. So hopefully by now I will have given you an idea of why it is clear that progesterone is so important in pregnancy. I'll tell you a little bit about what research there is out there that has, in many ways, justified where we're going with progesterone for the prevention of preeclampsia, and that stems from progesterone being used for the prevention of miscarriage. Well, in order for a pregnancy to be successful, it requires a normal embryo, a euploid embryo, and a receptive endometrium as well. And to me, it is quite helpful to break it into that dichotomy between embryo and endometrium, because what is clear is the fact that there is very little that we can do about embryonic ploidy. And in fact, if the embryo is aneuploid, then with some exceptions, some trisomies, inevitably, the vast majority of the time, it leads to a miscarriage. So there's very little that one can do about embryo quality in terms of preventing aneuploidy or treating aneuploidy altogether in the context of unassisted conception. Whereas with IVF, it is possible to do pre-implantation genetic testing, although that is also a controversial approach to some. But what we know from the existing evidence is that as people miscarry, the more they miscarry, the more they are likely to miscarry again. So that if they haven't had a miscarriage before, their baseline risk is about 11%. But after 3 losses, that risk will increase by increments of about 10 percentage points with each loss, and become about 42%. And that is the risk of another miscarriage occurring. What we also know from existing evidence is that despite the fact that the risk of miscarriage increases as people experience excessive losses, the rate of aneuploid miscarriage that is essentially under the responsibility of abnormal embryos, remains the same, whereas the loss of euploid embryos becomes more and more prevalent. And what that suggests is that the other side of this dichotomy really has a lot of room for improvement, particularly in people who may sustain recurrent miscarriages. And it was based on this knowledge that Ari Kumarasamy, my colleague and friend in Birmingham, developed the PROMISE trial, published in 2015. And this was a randomized controlled trial where the basis for the trial was thinking, well, it is true that women who have repeated miscarriages are more likely to have a subsequent miscarriage. And it is also true that progesterone is so essential for pregnancy. So why don't we give people with recurrent miscarriages progesterone from the point of a pregnancy positive test? Sorry, a positive pregnancy test, compare it with placebo and see whether that accrues any value in terms of live birth. And that was a negative trial published in the New England Journal of Medicine in 2015, where the risk ratio was 1.04, with a confidence interval ranging from 0.94 to 1.15 out of 836 participants. When the investigators faced that result, they started wondering about whether there were other subgroups of population that might benefit from subgroups of women who might benefit from progesterone. Because the truth is, every miscarriage trial, every trial that is designed to prevent miscarriage that doesn't involve pre-implantation genetic testing will inevitably be plagued by the fact that a significant proportion, about 50% of the miscarriages in the trial, will occur because of aneuploidy. And progesterone would never treat that, and nor would the placebo, of course. So that has huge implications upon power and trial design. So when Ari went back to the drawing board, he thought two things really. The first was, is there a way to improve the power of our trial? And the obvious answer to that was to increase the number of participants to account for the rates of miscarriage stemming from aneuploidy. And the second question he asked himself was, is there a way to identify something that may signify luteal defect more than purely repeated miscarriages? And that symptom was vaginal bleeding. So that then led to the PRISM trial, which was published in 2019, again in the NEJM. And PRISM effectively recruited a total of over 4,000 participants. And the plan was to give people progesterone versus placebo from the point of threatened miscarriage, so bleeding in early pregnancy, and trying to ascertain whether that actually prevented miscarriage. And again, that was a borderline trial with a confidence interval of 1.0 to 1.07 and a p-value of 0.08. However, when the investigators looked at a pre-planned subgroup analysis according to a previous history of miscarriage, it was clear that women who had the dual risk factor of previous miscarriage and bleeding in the index pregnancy experienced a significant improvement in a live birth rate of about 9%. And the other thing they identified was that there was a biological gradient whereby the more people miscarried, the more likely they were to respond to progesterone, so that those who had previously lost 3 or more pregnancies were definitely the ones who had the most amount of benefit. And then when the investigators looked at the totality of the evidence, there was good a good amount of evidence suggesting that progesterone offered some benefit, not just for threatened miscarriage, but also for recurrent miscarriage. So much so that NICE in the UK have now changed their guidance to offer vaginal micronized progesterone at a dose of 400 milligrams twice daily to women who have an intrauterine pregnancy and bleeding concurrently with a history of previous miscarriage. And this should be continued until 16 completed weeks of gestation. ESHRE have been a little bit more conservative with their guidance. They've focused specifically upon the biological gradient, whereby those who'd experienced 3 or more miscarriages were the ones who benefited most from progesterone. And for that reason, they only recommend progesterone for the prevention of miscarriage in these women. What is fascinating to me is that, having looked at the evidence, at the history of the evidence, it's absolutely fascinating that knowing that progesterone is so important in pregnancy, it is also the only intervention for which there is moderate quality evidence of some improvement in live birth rate and reduction in miscarriage risk in people who have who are at high risk of miscarriage. So then that led to the question, is there a world where, in addition to contributing to a reduction in the risk of miscarriage, progesterone may help treat or prevent other pregnancy complications? And what made us think about progesterone and preeclampsia was effectively lessons that we learned from frozen embryo transfers. And the reason for that is because as time has progressed over the past few years, the number of embryos in storage, at least in the UK, has increased substantially. So that between 2013 and 2018 alone, it has increased, the number of embryos has increased by more than sevenfold, so 700%. And that's very important because whilst those embryos increase in number, the success rates of frozen embryo transfers remain relatively the same. But importantly, the benefit of having frozen embryos is the fact that if women come back for treatment in the future, there is no further need to stimulate the ovaries, and we can simply thaw the existing embryo or embryos and then transfer it into the uterus again. Now, there are, broadly speaking, two different ways of preparing the endometrial lining for transfer of these frozen embryos. Some people would prefer to rely on the woman's natural cycle, which is what you can see on the left-hand side of the slide. And what happens is we usually monitor people's ovulation and then tend to administer progesterone right before the embryo transfer, and then transfer the embryos usually, or the embryo usually about 6 days after the LH surge has occurred. Some people would require a HCG trigger, in which case a lot of clinics would then delay transfer by about 1 day. But the crucial bit about natural cycle FET is the fact that because we're relying on that person's natural cycle, there will be a corpus luteum sustaining early pregnancy in addition to exogenous progesterone. What's really interesting and what tends to happen overwhelmingly, certainly in the UK, is the fact that if people choose to have a natural cycle, because each cycle is not exactly the same as the next one, there is a risk that in any natural cycle FET, there may not be a follicle that develops enough to sustain the endometrium and ovulate. There may also be an endometrium that doesn't thicken up to a point that we would think it is receptive enough to transfer the embryo. And for that reason, about 8% of natural cycle FETs are cancelled. And that can be pretty catastrophic from a psychological standpoint to women and their partners. And for that reason, overwhelmingly so in the UK at least, people have historically used what we call hormone replacement therapy, FET, and they still use them in the vast majority of cases. And what happens in HRT FET is instead of relying on the person's natural cycle, we administer estradiol followed for about 10 to 14 days, monitor women's uteri with transvaginal ultrasound scanning. And once the endometrium has reached a certain thickness, which one would hope would be about 7 millimeters or above, we can commence progesterone for about 5 days, usually vaginal progesterone, sometimes intramuscular, depending on where you are in the world, and then transfer that embryo on average on day 6 of progesterone replacement. Now, what happens in this type of cycle is that in about 95% of people, forgive me, by virtue of administering exogenous estradiol and progesterone, they don't ovulate. And if they don't ovulate, there is no corpus luteum. And what the epidemiological evidence has shown is that the rates of preeclampsia in people who have a natural cycle FET where there is a corpus luteum are non-inferior and non-superior to those in people conceiving without assistance, or in other words, a natural conception, whereas with hormone replacement therapy, FET, the rates of preeclampsia are at least doubled those of natural cycle FETs. And that has important implications, which were not entirely clear on where they stem from, whether it is through the lack of a corpus luteum or through an inadequate supply of progesterone in the cycle. And what's really interesting is that we focus on the placenta and placental maladaptation as the syndrome upon which many of its manifestations occur, and they include not just miscarriage and stillbirth, but crucially preeclampsia, placental insufficiency, and fetal growth restriction, and preterm birth. And we focus on placental disorders, which is absolutely the right thing to do based on the existing evidence, because the reality is placental insufficiency affects about 4 million pregnancies every year, and it is responsible for just over 500,000 fetal deaths across the world. And yet we're not good enough at preventing it or predicting it. So the prediction has improved somehow over the past few years, particularly with the use of algorithms that use serum and demographic markers and ultrasound markers to predict people's risk of developing early onset preeclampsia. But the reality is, even if we use those algorithms, the interventions for which there is evidence of benefit in terms of preventing preeclampsia are aspirin started around 11 to 13 weeks and a high calcium diet as well. And one might argue that if preeclampsia and placental insufficiency really stems from abnormal implantation, then the regulator at that point, the orchestrator of implantation, truly is the corpus luteum, and that we ought to try and do something to clarify what the role of the corpus luteum is in the development of placental insufficiency and hypertensive disorders of pregnancy. So what we thought we would do, sorry, this is just a repetition of the previous slides. What we thought we would do would be to look at the evidence to ascertain whether there was anything indicating that there might be a benefit in administering vaginal progesterone. And we conducted a systematic review and meta-analysis and found 11 trials, but we were specifically interested in finding out whether the timing of progesterone initiation made a difference, because as you can see from my previous slide, we wanted to know whether starting progesterone early in the pregnancy made a difference. And of course, there are two main indications for progesterone in pregnancy. The first one is the prevention of miscarriage, and we know that from the trials that I've just spoken to you about. And the second indication would be most commonly for the prevention of preterm birth. And for preterm birth, we generally start progesterone in the second and sometimes third trimesters. And what we found was that if one initiates progesterone in the first trimester, vaginal progesterone, we are inadvertently reducing the risk of preeclampsia by about 40%, so a substantial reduction. However, if progesterone was initiated in the second or third trimesters, then this no longer accrued any benefit when it came to reducing the risk of preeclampsia. And importantly, these were high quality trials to which we restricted the analyses. Now, what's also very interesting to me is the fact that when you find this, you then start exercising your confirmation bias and trying to find ways in which progesterone may well be implicated at a mechanistic level upon placental maladaptation. And the truth is, if one looks at the pathophysiology of preeclampsia, we have found at least 12 mechanisms implicated 12 mechanisms that implicate progesterone when it comes to the development of preeclampsia. I won't go into them in detail because this will be the topic of our next publication. But I will conclude by summarizing by saying that there seems to be some biological plausibility to the use of progesterone from early pregnancy to prevent preeclampsia. And the existing evidence, the interventional evidence does support this. And importantly, though, the rates of preeclampsia were secondary outcomes of these big miscarriage trials. And for that reason, we are now in a situation where what we need is large targeted RCTs where the participants should be women at a high risk of preeclampsia and given progesterone versus placebo to see whether that does lead to a prevention in preeclampsia. I'll just tell you a little bit about our future work. So Oxlupin is a cohort study that we're implementing in Oxford with the support of Oxford University Press and the Royal College of Obstetricians and Gynecologists in the UK to try and ascertain whether it is possible to shift the screening for preeclampsia to early on in pregnancy, as early as 5 to 8 weeks of gestation. The second element of this work, or the second work package of our future work, relies on the Oxwatch trial, or this Oxwatch study, sorry, which was another cohort which looked at the people's outcomes in pregnancy, but following them up from all the way before pregnancy until post-conception. And we'll do some mechanistic studies on these samples to try and develop the proteome of pregnancy, or to identify the proteome of pregnancy. And the interventional arm of this work will be the P4P trial, which will then compare vaginal micronized progesterone to placebo in women at high risk of preeclampsia to see whether that reduces the risk of hypertensive disorders in pregnancy. And this will have the support of the University of Birmingham, where Ari Kumarasamy works, and Tommy's, the baby charity. I would like to thank all my collaborators and also all of you who have been listening to this presentation. Thank you very much.